Welcome back to the deep dive. If you've ever tried to understand the nuts and bolts of attention deficit hyperactivity disorder, or ADHD,
Hmm.
and specifically how the medications actually work, at a molecular level, you know how quickly it can all get, well, pretty dense.
It really can.
So today we are taking a deep dive into the psychopharmacology of choice for ADHD, and we're going to peel back the layers to understand not just the drugs, but the precise neural circuits they're actually designed to tune.
Our mission today is, I think, pretty straightforward. We want to move past just the symptom checklist and really get into the neurobiology.
Right.
We're going to connect those core ADHD symptoms, attention, hyperactivity, and impulsivity, and link them directly to specific inefficient processing areas in the brain.
Okay.
The goal is to show you exactly how. Manipulating the foundational neurotransmitters, dopamine and norepinephrine, can restore the brain's ability to focus and execute.
And that understanding is just so essential because the clinical picture of ADHD has, it's expanded so far beyond that classic image of a hyperactive kid.
Oh, completely.
It's now recognized as a chronic lifespan condition, and it often shows up mainly as executive dysfunction, basically.
Wow.
The brain just struggling to organize, prioritize, and manage itself.
Yeah.
So that's why we really need to get the underlying infrastructure. Let's start with that infrastructure then. The prefrontal cortex, the PFC, we know the three major symptom categories: inattention, hyperactivity, impulsivity. They seem to map directly onto specific parts of this command center.
You can think of the PFC as mission control. And when ADHD is present, it's like specific consoles in that control center just aren't getting the right electrical current. The hypothesis is that these deficits come from inefficient processing in different PFC circuits.
Okay, so give us the breakdown. Where is something like sustained attention located?
So sustained attention, that ability to hold information long enough to work with it, like short-term memory, that's linked to the dorsolateral prefrontal cortex, the DLPFC.
DLPFC, okay.
And to assess how well that circuit's working, clinicians will use tests like the NBAC test. You're shown a series of stimuli, and in the trickier versions, you have to recall the item that appeared 1 or even 2 steps ago.
Wow, so that takes some real effort.
It requires sustained, effortful activity from the DLPFC. Exactly.
So the DLPFC is for holding information. What about selective attention? The ability to filter out noise and just focus on one thing.
That's governed by a different area. The dorsal anterior cingulate cortex, or dACC. This is your brain's distraction filter.
The distraction filter, I like that.
The most famous way to test this is the Stroop task. You've probably seen it.
Yeah, where the word RED is written in blue ink.
Exactly. And you have to name the color of the ink, not read the word.
That conflict between the automatic process reading and their required one naming the color forces the dACC to filter and suppress the irrelevant information. So the DLPFC is our working memory, dACC is the distraction filter. And that just leaves the behavioral symptoms to round out the trio.
Right. Impulsivity, the blurting things out, the excessive talking, interrupting, that's linked to the orbital frontal cortex, or OFC.
So social judgment?
Social judgment and inhibition, yes.
Yeah.
And then finally, motor hyperactivity, the fidgeting, the need to constantly move, that's localized to the prefrontal motor cortex.
What's really fascinating about this circuit mapping is how the source material emphasizes a shift away from rigid categorical diagnoses and more towards focusing on symptom dimensions.
It's a massive paradigm shift. I mean, think about it. Executive dysfunction is not unique to ADHD.
No, not at all.
If you look at schizophrenia or major depression or anxiety, patients often struggle with sustaining attention or filtering information.
Right.
So by focusing on the symptom dimension, let's say inefficient DLPFC activation, we start to understand why a medication targeting that specific circuit might help patients across different diagnostic labels. It points the treatment directly at the mechanism, not just the syndrome.
Which brings us right to the core neurobiological hypothesis.
Yeah.
Why are these circuits inefficient in the first place? It's because ADHD is, at its heart, a disorder of inefficient PFC tuning.
Regulated by norepinephrine and dopamine. That's really the crux of it. The primary issue seems to be low tonic firing of both NE and DA. Cognitive function operates on what we call an inverted U-shaped curve.
Okay.
Performance is excellent in the middle, the sweet spot where they're optimally balanced. If they're too low, you get inattention, poor function. But if they're too high, like during extreme stress, you become hypervigilant, anxious, and cognitively impaired.
So how do NE and DA work together to keep the PFC in that sweet spot, that high-performing zone?
Well, they use different receptors to get that precise tuning. If you look at NE first, low levels of norepinephrine preferentially stimulate these highly sensitive postsynaptic alpha-2A receptors.
And that's a good thing.
That's what you want for good PFC function.
Mhm.
But if stress elevates NE too much, it spills over and starts activating the less sensitive alpha-1 and beta-1 receptors, which actually impairs working memory.
So for cognition, alpha-2A is good, the others are bad. What about dopamine?
Dopamine needs to hit its own sweet spot for the D1 receptors. D1 is critical for PFC function, but it's the least sensitive. So if DA levels are too low, D1 just isn't getting stimulated enough. You need a moderate amount to optimize its activity.
We really need to pause here and clearly define tonic versus phasic firing, because this difference is, well, it's everything. It's the difference between a successful therapy and a drug of abuse.
It is. Tonic firing is that slow, steady background activity, the low baseline tone, and that's vital in the PFC for stability.
Okay, the baseline.
Phasic firing, on the other hand, is a quick, high-intensity burst. It's linked to motivation, reinforcement, learning, and it's most prominent in the nucleus accumbens, the reward center.
So the goal for ADHD is to enhance that slow, steady tonic signaling in the PFC. But the big phasic bursts are a problem.
A huge problem. While a modest increase in phasic signaling can help with motivation, the excessive bursts you see in substance abuse or acute stress, they actually worsen cognition. And that's what drives addiction, because they flood that reward pathway.
And this is where the mechanism gets truly mind-bending, the dendritic spine mechanism. We're talking about how the signal is actively gated inside the individual neurons that make up these PFC circuits.
Right. Imagine the dendritic spine, where the signal comes in, has a leak channel. It's called the HCN channel. If that gate is open, the signal leaks out. The message is lost. If the gate is closed, the signal survives and strengthens the connection.
Okay, so it's a bait.
It's a gate. And both the alpha-2A receptor for NE and the D1 receptor for DA control this gate, but they do it in opposition to each other.
So they're basically wrestling over the same control switch. What happens when NE hits that alpha-2A receptor?
Alpha-2A stimulation uses an inhibitory G protein, which it closes the HCN channel. This is the mechanism that allows the signal to survive. It increases the strength and clarity of the desired signal.
And what about when DA hits the D1 receptor?
D1 stimulation uses a stimulatory G protein, which opens the HCN channel. Now, this might sound counterintuitive.
Yeah, why would you want to open the leak?
Because by opening the gate just slightly, DA causes just enough of the background static, the noise, to leak out.
Oh, that is the aha moment right there.
It is.
So perfect tuning requires both. Alpha-2A from NE closes the gate to increase the signal, and D1 from DA opens it just a tiny bit to reduce the noise. You get optimal signal clarity.
And in ADHD, with deficient NE and DA, you get a reduced signal and way too much noise. The whole system is just poorly calibrated.
We've seen how these neurons are tuned in the moment. But how did the system get so poorly calibrated to begin with? Let's zoom out and look at the developmental side of things. We know the genetic component is enormous, something like 75%.
Yeah, the unifying hypothesis really centers on a delayed maturation of these PFC circuits. This delay happens to coincide with critical periods of synaptogenesis, so forming synapses,
Right.
and, crucially, synaptic pruning. That's the elimination of unnecessary connections, and it peaks around age 6. If that pruning process is delayed or inefficient, the entire circuit is slower to mature.
And we see this delay reflected in how the symptoms change over a person's life.
Absolutely. The overt motor hyperactivity and impulsivity, they tend to decline pretty significantly by adolescence, probably because those circuits do mature just later.
But the inattention sticks around.
The inattention and executive dysfunction persist reliably into adulthood. And what's really critical is that comorbidities, substance abuse, anxiety, conduct disorder, they just skyrocket as the person reaches adolescence and adulthood.
Which poses a massive clinical challenge, doesn't it? Especially for adults who show up with this chaotic mix of symptoms. I mean, what do you even treat first?
That is the critical sequencing question. In clinical practice, if there is active substance abuse, that has to be the priority. You can't effectively treat executive dysfunction if the patient is self-medicating or destabilizing their own system.
Yeah, that makes sense.
So often, treating ADHD gets seen as this fine-tune adjustment after you've addressed the primary mood or anxiety disorders that are often masking the underlying attention deficit.
Which has to lead to a lot of underdiagnosis.
Precisely. It's estimated that less than 1 in 5 adults with ADHD is formally diagnosed and treated, largely because the symptoms are just buried under layers of these secondary disorders.
And when you look at self-medication,
The nicotine link is just striking. Adults and adolescents with ADHD smoke at roughly double the normal rate. and it's because nicotine subjectively improves their symptoms. It rapidly enhances DA release and general arousal, temporarily pushing the PFC back towards that optimal zone.
Okay, so let's talk about how pharmacology corrects this tuning problem. The general principle for stimulants is to increase NE and DA output to move the brain into that sweet spot on the inverted U curve. We have two major types, starting with methylphenidate or MPH.
Right, so MPH has a very distinctive mechanism. It blocks the norepinephrine and dopamine transporters nets and DATs allosterically.
What does allosterically mean here?
It means it binds to a different site than where the neurotransmitter itself binds,
Hmm.
but it still manages to stop the reuptake pump from recycling the transmitters. And the D isomer is the one that's much more potent clinically.
The variety of MPH preparations on the market is just staggering. You've got immediate release, extended release, chewables, patches, suspensions. It really shows this obsession with delivery customization.
It does. And the goal is to customize that duration of action because of what we call the mystery of the deed. You need to achieve therapeutic coverage all day without it interfering at night. That's why you have these unique products like Jornay PM, which you take at night. But it only starts releasing the drug 10 hours later, so the patient wakes up already covered.
So how does that compare to amphetamine? Structurally similar, but I know it acts completely differently, especially at high doses.
Amphetamine is a competitive inhibitor and a pseudosubstrate. At therapeutic doses, it's mostly just blocking reuptake, so the effect is similar to MPH.
But at abuse levels.
At abuse levels, the whole mechanism changes. It gets transported into the neuron, where it inhibits VMAT2, the little transporter that stores dopamine in vesicles.
So it's breaking open the storage containers.
It's displacing DA from the vesicles, causing a flood in the cell, and then ultimately it reverses the DD, pumping massive amounts of dopamine out into the synapse.
So amphetamine is not only kicking the furniture out of the closet by inhibiting VMAT2, it's also reversing the door to cause this catastrophic flood out onto the street.
That is a perfect way to visualize it. And that catastrophic flood explains the difference between therapy and abuse potential. And it all centers on this concept of the critical therapeutic threshold.
You make that DAT threshold sound so reliable, that Goldilocks zone. But how often in practice do we actually hit that spot perfectly? Or are patients just cycling through formulations trying to avoid that evening crash?
That is the #1 clinical challenge. The therapeutic action is immediate, and it's directly linked to achieving about 50 to 60% DAT occupancy.
50 to 60%.
The Goldilocks ideal is rapid onset in the morning, sustained in that zone all day, and then a rapid drop below the threshold for bedtime. But clinical reality means many patients struggle with that late afternoon symptom crash or evening insomnia because the drug's decay curve just isn't perfect for them.
And the abuse potential is purely about the amplitude and speed of that occupancy.
Exactly. Rampant high pulsatile DAT occupancy, what you get by snorting or injection, causes euphoria because it triggers those massive phasic DA bursts in the reward center.
I see.
Slow, sustained delivery, like you get from controlled release products or lisdexamfetamine, which is a prodrug that enhances the tonic signaling without that catastrophic rush. The speed is everything.
So when stimulants aren't appropriate, or maybe they just don't work for someone, we shift focus to the noradrenergic system with more selective treatments. Let's start with atomoxetine.
Atomoxetine is a selective norepinephrine reuptake inhibitor, an NRI. It blocks nets, mainly in the PFC. And because the PFC has nets, inhibiting them increases both NE and DA right where we need them.
And crucially,
Crucially, the nucleus accumbens, the reward center, lacks nets, which is why atomoxetine has virtually no abuse potential.
and because it restores that tonic signaling over a full 24 hours, it has some unique advantages, especially for complex adult patients.
Yes, for patients with chronic stress, anxiety, or substance abuse histories, conditions often linked to that excessive phasic activity, atomoxetine helps restore balance. It enhances the slow, steady tonic signal and kind of calms down those problematic phasic actions. It gives this broad 24-hour symptom relief that's often really beneficial for anxiety comorbidity.
Finally, we have the alpha-2A adrenergic agonists. These seem to bypass the need for presynaptic release altogether.
They do. Agents like guanfacine ER and clonidine directly stimulate the postsynaptic alpha-2A receptors in the PFC. And as we discussed earlier, that's the action that closes the HCN channel. It directly strengthens the signal and enhances the whole network's connectivity.
And there's a big difference between those two options, isn't there?
A huge difference. Guanfacine is far superior for targeted ADHD treatment. It's much more selective for the alpha-2A receptor. Clinically, this means it's about 10 times weaker at causing unwanted sedation or lowering blood pressure than clonidine,
Okay.
while at the same time being 25 times more potent in actually enhancing PFC function.
Wow.
They're excellent as augmenting agents, and they're particularly helpful for patients who present with oppositional symptoms, argumentative or aggressive behaviors, which are often linked to very low NE-NDA in the ventromedial prefrontal cortex.
Looking ahead, it seems the focus is still on perfecting delivery. You mentioned things like the repurposed NRI viloxazine ER and a triple reuptake inhibitor, centanafidine. They're all just aiming to hit that Goldilocks profile.
Yeah, the field really recognizes that the core mechanism of action, optimizing that signal-to-noise ratio with NE's alpha-2A and DA's D1 receptors, that's the key. Everything else is about the elegance and the precision of the delivery system.
So if we just synthesize all this, ADHD is a circuit disorder. It's linked to inefficient PFC function. Treatment works by optimizing the signal-to-noise ratio. And the difference between therapeutic use and abuse is really just the speed and duration of how the drug occupies the DT.
That's the takeaway. Understanding the distinct roles of NE and DA allows clinicians to select treatments: a rapid stimulant for speed, a 24-hour NRI for stabilization, or an alpha-2A agonist for signal strength based entirely on the patient's specific symptom profile and their comorbidities. It turns guesswork into targeted, mechanism-based care.
So here's a provocative thought for you to explore after this deep dive. Considering the critical role of synaptic pruning, that process of eliminating unnecessary synapses in early neurodevelopment, how might future non-pharmacological interventions try to target the efficiency of that PFC circuit maturation to maybe prevent ADHD symptoms before they even solidify in the first place?
That's a great question. That focus on preventative developmental tuning, that's where the next frontier of research really lies.
Thank you for joining us on the deep dive. We hope this is giving you a clearer, more nuanced understanding of ADHD psychopharmacology.